Ricardo Cas- Professor Ricardo Casaroli. He's more or less from Barcelona, more or less from Brazil. So he can speak also Portuguese with us. And this combined program is really new in our department. So maybe the second or third time that we apply for this situation, and we are learning how to work in join work with them. So it's really a pleasure to have University of Barcelona with us. The idea, for who is not very familiar of what we do here, our study student will going to present her work. All the professor already received the work and already have the opportunity to read the work ahead. And after that, they are going to have time to ask their questions and to do the argument on the student. So Mariana, do you feel that you are ready to start?
Yes, can I share my screen now?
Yes, so you have 40 minutes to present. As you saw, it's a very dense work, so she will try to put everything in this presentation.
Can you see my screen here?
Yes.
Yeah.
Now it's in presentation mode.
Okay. So let's start, right? Good morning, everyone. Good afternoon, Dr. Ricardo from Spain. My name is Mariana Matioli da Palma. Today, I'm going to present my thesis, which was done under course supervision of the Universidade Federal de São Paulo and the Universidade de Barcelona to obtain the title of Doctor of Science. During this period, I had a combined scholarship that allowed me to do a fellowship at KZI Institute at Oregon Health and Science University. My thesis is about rare and ultra-rare inherited retinal and choroidal dystrophies. I have no conflict of interest, and this study was financially supported by CAPS and CAPS Print. Rare diseases comprise a group of infectious, autoimmune, oncologic, and genetic diseases. It's estimated that in the world population of 7.8 billion people, approximately 300 million people have one of the 7,000 existing rare diseases. 80% have a genetic etiology, and the majority begin in childhood. Historically, patients with rare diseases have been marginalized from society. In ancient Greece, in Sparta, the citizen had to present his kid to a council of Spartans. If this council assessed that the child was normal and strong, his father would take care of him until he was 7 years old. Then the state directed the child's education to the art of war. However, if the child had any physical or intellectual limitation, the elders would stay with the child, and in the name of the state, the child would be thrown into an abyss, as they had the opinion that a child with disability was not good for the Republic. During the 20th century, people with disabilities and rare diseases were subjected to scientific experiments in Nazi Germany. As late as the 21st century, albinos were persecuted, mutilated, and excluded from society in East Africa. The definition of rare diseases based on the low prevalence in the population was established in the Orphan Drug Act of 1984 in the United States. This act sought to implement a public policy for the development of orphan drugs designed to prevent and treat rare diseases. According to definition of the World Health Organization, which is the same definition followed by Brazil, rare diseases affect 65 individuals for every 100,000 inhabitants, or 1.3 for every 2,000 inhabitants. In addition to definition of rare diseases, there is also ultra-rare disease, defined as any chronic, debilitating, or life-threatening disease with an incidence less than or equal to 1 in every 50,000 inhabitants. The primary objective of this study is to characterize how rare and ultra-rare diseases are present in ophthalmology and contribute to the understanding of the clinical characteristics, the natural history of the disease, the pathophysiology, metabolic pathway of the genes, and identifying new phenotypic and genotypic characteristics. As secondary objective, evaluate the presence of rare and ultra-rare inherited retinal and choroidal dystrophies to correlate them with the clinical and genetic characteristics already described. Characterize ophthalmological findings through multimodal retinal examinations and functional tests to contribute to diagnosis and follow-up. Contribute to precision diagnosis through reclassification of variants, validation of the pathogenicity of variants, and use of new disease nomenclatures. Disseminate the importance of ophthalmologic and genetic examination in the pediatric population in order to promote earlier and more accurate diagnosis. Evaluate existing treatment pathways and contribute to new therapeutic possibilities, in addition to indicating new biomarkers of response to treatment. This research was approved by the Ethics Committee of the Federal University of São Paulo. I was also part of a study approved by the International Review Board of the KZI Institute at OHSU. This is an observational and retrospective study, analysis of medical records of patients with rare and ultra-rare inherited retinal and choroidal degeneration, which may be associated with syndromes, analysis of multimodal retinal exams, functional exams, and genetic testing were made. The university allows PhD defense as a compilation of published papers. This PhD defense is composed of the following publications. In the first paper, Rare Disease Day in Ophthalmology, we wrote a letter to the most well-known journal in Brazil about Rare Disease Day, which is celebrated every last day of February. The goal of these days is to generate awareness in the public and health professionals on the effects of these rare diseases on patients and their families. Many patients are struggling, searching for diagnosis and appropriate treatments. Many rare diseases affect ocular tissue, such as retinoblastoma, an ocular cancer, Zika virus syndrome, a congenital virus infection, and congenital cataracts. Ophthalmology stands out for its recent advances in the field of rare diseases. Inherited retinal dystrophies comprise a group of ophthalmologic diseases marked by great clinical and genetic heterogeneity that affect around 1 in every 2,000 to 3,000 individuals. These disorders are considered rare and some of them ultra-rare. The first gene therapy approved by the FDA was for treating patients with an IRD, the RPE65 biallelic dystrophy. Luxturna was also approved by the Brazilian Health Regulatory Agency, Anvisa, for treatment in Brazil. During studies to approve Luxturna, the subretinal injection was created manually with an assistant pushing a syringe, as we can see in this photo of the leaflet. After a posterior vitrectomy with posterior vitreous detachment, the virus vector solution is injected into the subretinal space. The subretinal space is an area with little immune response and allows contact of the virus vector solution with the photoreceptor cells. It's necessary to optimize surgical protocols for subretinal injections. In the second paper, injection pressure levels for creating blebs during subretinal gene therapy, we evaluate pressures required to initiate and propagate subretinal blebs of 70 patients treated using pneumatic-assisted subretinal delivery system. Note that the pre-bleb injection pressure, 8 psi, was higher than the pressure needed to propagate the virus vector, 5 psi. All subjects were brought to the operate theater and placed in supine position. General anesthesia was induced prior to perform 23 gauge pars plana vitrectomy using Constellation Vision System. The intraocular pressure was maintained at 10 millimeters of mercury during bleb initiation and propagation. The Constellation was set up for foot pedal controlled injection using the viscous fluid injection mode. And in most cases, the maximum pressure in the viscous fluid injection mode was set up 16 psi. The minimum pressures required to form pre-blebs were significantly higher than those used to propagate vector solution, 5 versus 4 psi. Only 14 patients had injection pressures greater than 10 psi during pre-bleb formation. The youngest patients group, made up of patients aged 4 to 20 years, required significantly greater pressures for vector propagation than the oldest group. We want an injection pressure that may provide a stream of droplets, able to provide a continuous flow. Elevated injection pressures, as I'm showing here, may increase flow-related complications such as overstretching or thinning of the retina. Avoidance of these adverse events is paramount to the success of gene therapy surgery. Our team achieved relatively low injection pressures for vector propagation, likely by prolonging the injection time to allow for gentle dissection of the adherent retina. The median time for bleb propagation was 4 minutes, for a median volume of 155 microliters. The median rate was 33 microliters per minute, and this data has important implications in optimizing surgical protocols for subretinal injections. Numerous gene therapy trials are ongoing to test safety and efficacy of gene therapy across different diseases, such as achromatopsia, retinitis pigmentosa, and choroideremia. To participate in these clinical trials, a conclusive genetic testing is required, which is not always easy. In the third paper, synonymous variant in the SH-M gene causes aberrant splicing in choroideremia, we demonstrated this difficulty in concluding a diagnosis in a patient with inconclusive genetic testing because a variant of uncertain significance was found, a synonymous variant. The change of cytosine to thymine at position 1359 in the DNA did not result in amino acid change in the protein. So the codons TCC and TCT code for the same amino acid serine. So this is a synonymous variant. The nucleotide change does not result in amino acid change. The patient was a 58-year-old man with a best-corrected visual acuity of 20/50 in the right eye and 20/80 in the left eye with diffuse chororetinal atrophy and a reminiscent autofluorescent island in the macula area in both eyes. The patient had a clinical diagnosis of choroideremia, and his carrier daughter had no ophthalmologic complaint. She had good visual acuity in both eyes, and autofluorescence showed this pattern of autofluorescent changes in the macula area in both eyes, typical for carrier women. We performed RNA analysis on the proband and his daughter, analysis of the fragment gels, analysis of the agarose gel fragments showed that the heterozygous daughter had a main fragment of 343 basic pairs corresponding to the wide transcript, and a minor band of 279 basic pairs, while the hemizygous proband had the same band of 279 basic pairs with significant intensity that we called as alternative 1, causing an error on the processing of RNA messenger, leading to an aberrant transcript without exon 11. Note that the nucleotide changes in the beginning of exon 11, leading to an aberrant transcript without this exon 11. A patient with a clinical diagnosis of an ultra-rare disease, choroideremia, and an inconclusive molecular diagnosis could not participate in any therapy being studied or approved. The molecular study proving the pathogenicity of the synonymous mutation found in the SHM gene allowed the patient to be considered to enrollment into gene therapy trials. And in addition to gene therapy, there is also dystrophy for which treatment is based in vitamin supplementation and diet. This is a fundus photo of a patient with classic gyrate atrophy, characterized by these demarcated ellipsoid areas of chorioretinal atrophy. In a possible ocular biomarker for response to hyperornithinemia in gyrate atrophy, we discussed the diet in a patient with advanced disease and a possible novel biomarker for ornithine reduction therapies. The patient was a 51-year-old female patient with best-corrected visual acuity of 20/50 in both eyes with diffuse chorioretinal atrophy. She was first diagnosed with retinitis pigmentosa when she was 16 years old and definitively diagnosed with gyrate atrophy only after her 5th decade of life due to hyperornithinemia, and genetic testing found 2 heterozygous variants in the ornithine aminotransferase gene. The delay in her diagnosis led to a delay in her treatment. The mean sensitivity of static visual field was 1.6 decibels in the right eye and 1.2 decibels in the left eye. Static visual field average sensitivity was plotted over time and overlaid with plasma ornithine levels, as I'm going to show in this graphic. Before starting treatment, her ornithine levels was elevated at 961 micromoles per liter. She was prescribed vitamin B6 or pyridoxine, and then she was prescribed lysine 15 grams per day. However, lysine was discontinued due to hyperammonemia. Arginine-restricted diet was initiated, and after 18 months in a 4-step diet, she achieved ornithine levels less than 500 for nearly 1 year. The lowest level of 275 micromoles per liter, a reduction of 71% from baseline. During this period, the mean sensitivity average on static visual field appeared to stabilize. However, during pandemic, she had difficulty with diet and she discontinued diet and vitamin B6 supplementation. Ornithine levels rose above 500 again. During this period, we detected a change in ellipsoid zone thickness correlated with plasma ornithine levels. EZ became thinner and less reflective at lower ornithine levels. In the OCT evaluation, a change in thickness in the ellipsoid zone was detected, which could become a biomarker of response to existing and developing therapies. we observed a thickening of the ellipsoid zone when ornithine levels were higher. Therapy with vitamin B6 supplementation and a restricted arginine diet should be prescribed even in advanced cases of the disease. So I showed a patient with choroideremia with an X-linked inheritance pattern whose treatment is under study. I showed this patient with gyrate atrophy with an autosomal recessive inheritance pattern whose treatment is based in vitamin supplementation and restricted arginine diet. All these three patients show diffuse cardioretinal atrophy in the same decade of life. So which is my third diagnosis? Do you think genetic testing is important here? Do you agree genetic testing contributes to accurate diagnosis and follow-up? In the fifth paper, Expanding the Phenotypic and Genotypic Spectrum of Biatic Crystalline Dystrophy, we reported 4 unrelated patients with BIET. By looking at the fundus exams of these 3 patients, 3 female patients at different ages, we are able to see the progressive nature of the disease. The youngest patient had the milder phenotype as expected. It is also expected that the disease progresses to diffuse cardioretinal atrophy and diminution of the yellow-white crystals. The youngest patient was a 19-year-old female patient with best-corrected visual acuity of 20/20 in both eyes. Fundus exam showed diffuse crystalline deposits in both eyes. Genetic testing found a pathogenic variant, more frequently reported in Asian patients. This patient reported her maternal grandparents were from China and her paternal grandparents were from Japan. The fundus exam of the second patient, a 54-year-old female patient, showed that we can see less yellow-white crystals and we can see cardioretinal atrophy associated with bone speckles. Fundus exam of the oldest patient, a 69-year-old female patient, showed that cardioretinal atrophy was more evident. But homozygous variant was found, and this patient reported consanguinity in her family. The most severe phenotype was found in this 59-year-old man with best-corrected visual acuity of light perception in the right eye and hand motion in the left eye. He reported he was first diagnosed with retinitis pigmentosa when he was 34 years old, and re-reported posterior vitrectomy due to macular hole and retinal detachment at age 40. Fundus exam showed diffuse cardioretinal atrophy, absence of yellow-white crystals. We can see in the right eye the presence of silicone oil, and in the left eye we can see macular hole associated with localized retinal detachment. We can see a boundary between attached retina and the detached retina here. Genetic testing found a novel, likely pathogenic variant in the CYP4V2 gene. This gene, which most often affects Asians, was found in Brazil, which has the largest Japanese population and people of Japanese descent outside Japan. A better understanding of the natural history of the disease is also essential, as in most cases we are facing progressive disease as demonstrated by the distinct stages of Biatic crystalline dystrophy. No therapy is available for Biatic, hence the importance of better understanding the natural history of the disease and the pathophysiology of the gene involved so that new therapies can be developed. So the differential diagnosis of diffuse cardioretinal atrophy includes choroideremia, gyrate atrophy, Biatic, retinitis pigmentosa, and fundus albipunctatus. The crystalline deposit seen in the early stage of Bieti is the hallmark of the disease. However, these crystalline deposits can be seen in other retinopathies, such as retinitis punctatus albicans, stenosis, Sjogren-Larser syndrome, and Alport syndrome. We need to be aware when suspecting of an IRD, we may be facing an ocular syndrome with the disease manifesting in different organs, not only in the eye. The most common ocular syndrome is Usher syndrome. Usher syndrome is divided into 3 types depending on the severity and the age of onset of sensorineural hem loss and retinitis pigmentosa. In expanding the clinical phenotype in patients with disease-causing variants associated with atypical Usher syndrome, we described the clinical features associated with 4 genes that did not fit into the 3 classic subtypes of Usher syndrome. Everything started with this 69-year-old female patient with best-corrected visual acuity of 21,000 in the right eye and 2,800 in the left eye. She reported visual difficulties from the age of 40 and hearing loss from the age of 50. Fundus exam and autofluorescence showed disparton of pericentral changes, and OCT showed central atrophy. Genetic testing found a homozygous variant in the arisofatase G gene. According to Omin, this gene is associated to Usher syndrome type 4. To avoid numerous types of Usher syndrome besides the 3 classic subtypes, we prefer to use the terminology of atypical Usher syndrome. This is a figure of our paper showing 3 patients with atypical Usher syndrome associated with ARSG gene. Mutations in this gene is rarely found in the population, so a multicenter study was necessary. Even with advances in genetics and medicine, many patients are underdiagnosed. With the increase in molecular knowledge, new nomenclatures and classifications are necessary, as in the case of atypical Usher syndrome, a term that covers cases that do not fit into the classic subtypes. We presented atypical Usher syndrome associated with different genes from different universities. Genetic testing was essential for accurate diagnosis in this series of ultra-rare and atypical cases. Some genes associated with Usher and atypical Usher syndrome are ciliopathies, which affect the photoreceptor connecting cilium. Ciliopathies show great genetic heterogeneity and involvement in different organs. The centrosomal protein 78 and the centrosomal protein 250 associated with atypical Usher syndrome are considered ciliopathies. In the 7th paper, TubeGCP4 associated microcephaly and chorioretinopathy, we suggested that the disease associated with this gene should be considered as a ciliopathy. We described a Brazilian patient with microcephaly and chorioretinopathies with clinical features never reported before, such as scoliosis, acanthosis nigricans, and centripetal obesity. Her mother reported she had abnormal fundus exam since nursery. Genetic testing found 2 heterozygous variants in the TubeGCP4 gene at age 10. At age 12, she was legally blind with a best-corrected visual acuity of 2400 in both eyes. Fundus exam showed this punched-out appearance of the chorioretinal lesions in both eyes, typical for this gene. Microcephaly and chorioretinopathy type 3 is part of the differential diagnosis of infectious diseases that affect the infantile retina, such as toxoplasmosis, rubella, cytomegalovirus, herpes simplex, and Zika virus. Vision is essential to the physical, emotional, and cognitive development of children. Ophthalmological examination in children is very important. In characterization of the spectrum of ophthalmic changes in patients with Alagille syndrome, we described a retinal finding that may help diagnosing this syndrome that affect infants. Alagille syndrome was described by Daniel Alagille, who began studying children with biliary disease. The ocular features of Alagille syndrome were discovered later and form part of the criteria for diagnosing this disorder. The classic criteria to diagnose Alagille syndrome was established in 1987 and required a paucity of the interlobular bioducts and at least 3 of 5 major features, which included chronic cholestasis, dysmorphic facies, cardiac disease, musculoskeletal anomalies, and ophthalmic changes. Posterior embryotoxin was considered the most frequent and important ocular finding. This 1987 paper from Daniel Alagille shows posterior embryotoxin as this white line demonstrated by the arrows in this black and white photograph. These 2 patients with Alagille syndrome shows posterior embryotoxin in this colored photograph. Posterior embryotoxin is an asymptomatic feature and can be found in 8% to 15% of normal individuals. Using an ultra-wide field camera, we're able to see this well-demarcated circumferential chororetinal atrophy bilaterally in the periphery in a patient with Alagille syndrome. Autofluorescence also showed this well-demarcated circumferential hypoautofluorescence that correlated with loss of function, as we can see in her constricted kinetic visual field. Due to the importance of these findings, we decided to carry out a multi-center retrospective study in which we evaluated 23 patients with clinical diagnosis of Alagille syndrome and found 6 novel variants in JAK1 gene, the gene most frequent associated with Alagille syndrome. Hepatic and musculoskeletal changes were found in 16% of patients. Cardiovascular changes were found in 83% of patients. Murmur was the most frequent finding. Regarding ophthalmic findings, ocular symptoms were found in 91%. Peripheral vision issues were the most frequent complaint, followed by nyctalopia and photophobia. Changes in the anterior segment were found in 74%, with posterior embryotoxin being the most common one, 70%. On the other hand, posterior segment changes were found in 96%. Optic nerve changes were found in 52%, and peripheral retinal changes in 96%. Only 1 patient had a description of normal periphery. These peripheral changes were able to see better using an ultra-wide field camera. As we can see in these photos, we can see the peripheral retinal changes correlated with loss of autofluorescence and also with loss of function, as we were able to see by looking at the kinetic visual field of the patients that underwent this exam. This study is the largest case series of Alagille syndrome, focusing on multimodal retinal findings using wide field cameras. Retinal changes in the periphery were associated with peripheral vision loss and nyctalopia. Peripheral chororetinal changes were more frequent than posterior embryotoxin, the classic asymptomatic ocular feature of Alagille syndrome. We suggested the presence of peripheral chororetinal atrophy may help in diagnosing this syndrome. With technological advances in ophthalmology and genetics, diseases that were not previously described in the pediatric population can now be diagnosed. invariable expressivity of bestrophin 1 associated autosomal dominant vitreoretinal-choroidopathy aardvark in a 3-generation pedigree, we described the youngest case of aardvark in the literature with visual impairment in early childhood. Family reported that the proband at 20 months of age were bumping into things and experiencing night difficulties. Fundus exam showed diffuse RPE atrophy and visible choroidal vessels. Autofluorescence showed loss of autofluorescence in the mid and far periphery. Sedated fulfill ERG showed severe rod cone dysfunction in both eyes. On the other hand, her father at age 39 showed a pattern of moderate rod cone dysfunction in both eyes. So this is the variable expressivity of aardvark within the same family. Fundus exam showed a well-demarcated region of retinal atrophy in the retinal periphery, and autofluorescence showed peripheral hypoautofluorescence. The paternal grandmother had a follow-up of 30 years at KZI Institute. All the pictures in the right at age 59 compared with old pictures in the left show progression of the disease over time, as you can see better here looking at the autofluorescence. The fulfill ERG showed progressive rod cone dysfunction over time as well. This patient was first diagnosed with ADNIV, autosomal dominant neovascular inflammatory retinopathy, which is an inherited autoimmune disease. Genetic testing found a variant in the bestrophin 1 gene, one of the 5 variants already described in association with aardvark. This gene has a phenotypic heterogeneity. That means different variants in this gene is associated with different phenotypes, such as retinopathy that affect the macula area, best vitelliform macular dystrophy or adult vitelliform dystrophy, and retinopathies that primarily affect the periphery, such as aardvark. There are also genes historically associated with syndromes that have been recently associated with non-syndromic conditions. In expanding the phenotypic and genotypic spectrum of patients with HGSNAT-related retinopathy, we described 11 patients with isolated retinitis pigmentosa without signs and symptoms of mucopolysaccharidosis type 3C. Most of the patients presented with this pattern of pericentral retinitis pigmentosa. Kinetic visual field also showed this pattern of pericentral dysfunction. The age of ophthalmic symptoms onset varied from 15 to 72. The median age at last visit was 47. The median best corrected visual acuity was 20/20. And the variant alanine changed to threonine at position 615 was the most common one found in our cohort. It was observed homozygosly in 3 patients and heterozygosly in 5 patients. This variant has a relatively high prevalence in the population and was defined previously as a benign polymorphism. Other authors have described patients who were homozygous for this variant, and it has been reclassified. 2 of our 3 patients homozygous for this variant had an onset of ocular symptoms after the 8th decade of life. In summary, it's important the continuous ophthalmologic assessments of children, young, adults, and elderly people, and the suspicion of genetic conditions, syndromic or not, in different age groups. Okay, so during these years studying ocular genetics, I have learned a lot. I also learned that there is also something new to learn. So I showed this fundus exam of a patient with Alagille syndrome, showing this chorioretinal atrophy in the periphery that may help in diagnosing this syndrome, this finding. I also showed 3 patients with the same phenotype, diffuse chorioretinal atrophy, with different diagnoses, with different follow-ups, with different genetic counseling, and one of these patients had treatment based on restricted diet. I showed the fundus exam of the youngest patient in the literature with ADVERC, and at the same time I showed this patient with a likely normal fundus exam, with the onset of ocular symptoms at age 72, after the 8th decade of life, with an IRD associated with a gene historically associated with a syndromic conditions, mucopolysaccharidosis type 3C or Sanfilippo syndrome. Physical exam, multimodal retinal images, functional testing, and genetic testing were essential for the best approach of the cases addressed here today. However, many patients still remain undiagnosed, untreated, and without adequate support, making the efforts of the scientific community necessary. Vision loss leads to reduced quality of life and a decreased level of autonomy and performance in daily school and work activities, leading to emotional, social, and economic impact on patients. It's essential to motivate the government, universities, researchers, health professionals, and the private sector to pay more attention to rare and ultra-rare inherited retinal and choroidal dystrophies. In conclusion, this thesis addressed distinct aspects of rare diseases and the prominence of ophthalmology among rare diseases. Ophthalmology has an approved gene therapy for an IRD, and there are ongoing clinical trials. The most common route of gene therapy is injection into the subretinal space, which requires the best surgical technique. Understanding the natural history of disease and finding new biomarkers as a response to treatment improve follow-up assessment. Most treatments emerging are gene-specific, requiring identification of the genetic mutation and conclusive diagnosis. However, genetic testing is not widely accessible and is not always conclusive, making it valuable to report cases and reclassify variants. A physical examination should be associated with genetic testing for an accurate and early diagnosis. Some ERDs are also part of syndromes that require a multidisciplinary network. The new phenotypic and genotypic characteristics of these diseases described in our study will allow for a better understanding of the pathophysiology and metabolic pathway of the gene involved, which contributes to identifying new targets and future therapeutic strategies. My special acknowledgements go to the Universidade Federal de São Paulo for generating opportunities, to the Universidade de Barcelona for allowing this course supervision agreement between both universities, to Oregon Health and Science University for welcoming me as an international fellow, to CAPS for the financial support, to the prestigious committee members that accept the invitation to be here today in this special moment, to Joelma Silva for her support in the postgraduate program. I am especially grateful to Professor Dr. Juliana for being an inspiring professor and for providing priceless direction throughout my PhD program, to Professor Dr. Ricardo, who has always encouraged me to keep doing this, to Professor Dr. Pinisi for believing in me and for his wiser supervision during my sandwich doctorate, to Professor Dr. Paul Yang for his extraordinary teachings. I would like to thank my co-authors because of their efforts and hard work. I must thank many professors, colleagues, and friends that made this journey more adorable. Last not least, my family for all the love and moments together. Thank you for being here with me today. I would be happy to answer any questions or comments one at a time you must have at this time. Thank you very much.
Thank you, Mariana. Well done, just in time. Congratulations. But it's a lot of information to organize in such a small period of time. It's really been an honor to be your teacher and take care of you during those years. Being a teacher, I understand that I receive the student in a certain level and I have to deliver the student in a higher level. And I think you were proving that today. And I would like to highlight the presence of a lot of people in the room. And among them, I would highlight two people, João Abujanra and Caio Abujanra. They were from the beginning. I met Mariana for the first time at Professor Suel Abujanra's clinic, and now they are taking care of the clinic. So thank you for both of you to present Mariana to me. And so you were part of the story that allowed her to be here today with all this team. There's a lot of people that work with Mariana in many of the clinics. Special presence here of Professor Mark Panesi that just said some words in Portuguese. Okay. He is a very good friend, and having friends, it make my job much easier because I can work as a team and send the student outside where they are exposed to other technologies, other ways of thinking. So it's really, I'm really thankful for what you did for Mariana. And I would add to this list also Po Young, that is also here. And I would also thank Andrea Zing to be also in the standby professor here. Ronaldo Lima and Maria Fernanda Valem to all their help. Marcela is here representing the Patient Association. And I can see many names here that are co-authors of Mariana. I saw during Sgedar that she made a lot of friends at KCI. So I'm really happy that she took very good profit on all the opportunities she had and all the publications she has. But today we have some invited professors to evaluate her work. And it's really, really an honor to have Irene Momini as a professor here. So we first invite to speak people that are from a far distance academical connaissance of the students. So Irene, I think it's you to be the one to speak first. It's really hard to say from where she is. She's from the world. She's teacher and professor of everybody. At the moment, she's at the Columbia University in New York, but she has been in many other universities. So she's my professor, and I think now she's grandmother professor of Mariana Matioli. So Irene, we would like to hear your considerations. You have 30 minutes to speak, and Mariana can answer, or you can go both of you together. So you ask and she answers. That would would allow you more time?
I think it's more efficient to go back and forth. So, you know, it's more coherent and people forget the questions and so on. First of all, my congratulations to Mariana. I think this is a wonderful piece of work. And you have really put together a training program that will serve you very well for the future. And we'll get back as some of the last questions of where you see your future. But let me ask you first some pretty sort of banal questions, maybe, where you may have more experience than I do. Did any of your allergy patient need a liver transplant? Traditionally, they don't, and I presume it is no. And the second question with the allergy syndrome is, you know, is that retinal change progressive? I have seen that retinal change, and it seems to be stable, but maybe you have some patients who have a longer follow-up. So if I may ask you to comment on those two things. The liver transplant and whether the retinal periphery changes are progressive.
Thank you, Dr. Irene, for your question, and thank you for being here today with us. We really admire the work you have been doing for these years. And about Alagille syndrome, some patients underwent liver transplant, around 8 patients.
Wow.
And yes, and one of these patients, she died because of complications of the liver transplant. So this is not a follow-up study, so we are not sure if these peripheral retinal changes is progressive or not. But we believe that can be, because in the figure where we put the youngest patients first and then the oldest patients in the end of the figure, we can see that there is a tendency of the oldest patients had major atrophy than the youngest patients. And our cohort was made up of patients aged 3 until 50 years old. So they are not so young. And these kind of peripheral changes were not described earlier. So maybe because it's not well seen in early childhood. So we are not sure, but we believe it's progressive. And yeah, but based on my research, I can't tell because it's not a follow-up study.
Sure.
Yeah.
Okay, thank you. You know, I've seen several patients with this, and their liver problems seem to be pretty severe in the first year, and they kind of outgrow it traditionally. So I'm amazed that you needed a liver transplant in such a high number of patients. So that's very interesting, and certainly changes the prognosis as far as I'm concerned for that condition.
Irene, Professor Mark Panesi just raised his hands. Maybe he wants to add something.
Sure.
Yeah, I want to ask a question, but I also just want to say something real quick and just say, first most, how much of a pleasure and an honor it has been to mentor Mariana over the years. And as you can see from her presentation, she definitely has the brains, but what this doesn't show is the heart that she has and how deeply she cares for her patients. And she is just a wonderful doctor. And with that, though, I do have a question I want to ask. So you presented 3 different diseases, adverk, heparan sulfate, and Alagille, that all show this pattern of kind of very peripheral degeneration. 3 different genes. Can you maybe hypothesize a unifying hypothesis of why do all of these different genes give you this similar pattern of degeneration?
Yes, it's a great question. And this question related about what I'm interested in keep studying, the peripheral retina, because I think the peripheral retina can tell us much more than we think. And it's interesting that studying all these papers, there is something in common, that is there is some genetic problem during the eye development. So in some papers some papers about ADVRC, they showed that bestrophin 1 gene is more dislocated during embryonic periods. And about Alagille, most of the patients, more than 90% of the patients, they have disease associated with JAG1 gene, that is a gene associated with nocturnal pathway. And this pathway is very important during the embryonic period. So something during the embryonic period is happening that leads to these peripheral changes. I don't have the question, but this is like a hypothesis. Yes, for sure. Is that?
Yeah, I think I think you're onto something, and I agree. And, I think the same goes for the heparin sulfate. So, I have thought the same thing, for a long time, that there is something, fundamentally different about the far periphery, and it is something worth investigating. So I think maybe you should do that.
Yes, I am really interested in studying the peripheral retina now after these studies.
Good. Certainly, the peripheral retina and late onset diseases are the two territories where the studies in the retina ought to go, isn't it? It's just there's a lot of lack of knowledge in late onset retinal diseases. You inherit your macular degeneration, your age-related macular degeneration, even though people think it's, environment, diet, and who knows what all, but I'm sure in the end, a large proportion will be genetic. But we'll see what time brings. So thanks for that. Another sort of shorter thing is, you described this acanthosis nigricans in a patient, and also truncal obesity in your patient with microcephaly and developmental delay and in chorioretinal atrophy. This acanthosis nigricans and chorioretinal and truncal obesity, in my view, was always caused a sign of Bardet-Biedl syndrome. So I was totally surprised to find that in this condition. Have you seen that in other patients? Does the patient have any other mutations? Is there anything special going on? So I don't know. Is it a common pathway? How do you explain this one? Is it a special subtype in the Bardet-Biedl syndrome? I don't know whether they all get acanthosis nigricans. I don't know of enough genotype-phenotype correlation work in definition of the extraocular findings in Bardet-Biedl patients. Do you have more information on that?
Yes, this is a Brazilian patient with tube GCP4, and this gene is rarely reported in the literature. Before this paper, only one paper describing 4 patients was found. Yeah. So one of these 4 patients had obesity from the age of 2. So, and this gene is associated with some changes in the microtubule organization. So we suggested that these could be associated with a ciliopathy, and because of that, being associated with obesity and all these changes. This patient in our report, she also has hypercholesterolemia. And maybe because of the obesity, her hormones are not good as we think should be. And because of that, she's having these acanthosis nigricans that can be associated with some glucose or insulin problems.
Okay. Well, I think we need to keep our eyes out to see whether we see that in other patients. Indeed, the patients with microcephaly and chorioretinal dysplasia, I think there are 3 known genes. They're individually so rare that it will be hard to put data together. But this was just the first time that I hear about acanthosis nigricans in them. So, and also the body habitus. She looks like a body beetle patient when you look at her. So, you know.
Yes, she looked at it as a Bardet-Biedl, but the acanthosis itself is more related to the obesity and resistance to insulin than as a primary phenotype related to the ciliopathy. It goes with the obesity.
Okay. It's Helen Ollendorf. I don't know whether her name came up when you're looking at acanthosis nigricans. She spent her life looking at that disease out of, I think she was at Cornell, but she was definitely in New York. And maybe she has some more insight on that. And I didn't go and look back at her work. So it's Helen Ollendorf. Now it comes to you. What changes do you want to make in the future in genetics, in ophthalmic genetics? Where do we see you go?
Okay, so at KZI Institute, I was able to see a generation like Richard Welleber and the new generation now. And as there are a lot of ongoing clinical trials over there, and Luxturna is approved, and there are a lot of patients that underwent this gene therapy surgery. So the difference is that we are able to ask the patients what have been changing and what are the things that they can see now that they were not able to see in the past. So for me, this is the new ocular genetics that I want to be in and to fight for, that we can have more clinical trials, more approved studies that can bring ocular improvement for the patients, and for us as a doctor to have these kind of questions to our patients. What is better now? What you can see that we couldn't? So you
might go into gene therapy.
Yeah, what I want to go more, this is
participate in gene therapy.
Yeah, this is one thing, because we can see changes, but also doing all these studies. I love to study the genetic pathway, so we are able to understand the disease better, and these kind of associations that we can do now between what we see in the fundus exam, using ultra-wide field exams, and the genetic testing, what they are showing, if we can see some clinical features that can help diagnosing the disease, and that can help understanding the natural history of the disease, and also how to follow up better these patients. Because it's good when we are studying something and we can put in our daily life, right?
Yeah, I always put genetic eye disease and genetics in general as public health issues. And I think it needs to be applied worldwide. It's just that idea that they're public health issues for a given country. And how do you think that your place can contribute to the help with genetic blindness in Brazil? Will you have a teaching program on your own? How do you see things expand?
Yes, as most of you know, during my residency and fellowship program, I didn't had ocular genetic training. So at the Universidade Federal de São Paulo, we have this kind of training, but it's not, in Brazil, it's just few places that we can have genetic as something that we can learn and we can teach and we can do in our daily life. So I think first we need more ocular genetic specialists that we can work together and have more regions in Brazil with this kind of specialist. And of course, we have some issues here in Brazil. Genetic testing is not approved by the Unified Health System, the agency that regulatory all the insurance. They don't approve genetic testing for retinopathies, and gene therapy is not also approved. And we have a lot of barriers to work with here in Brazil. But we have Dr. Juliana, like the first one, fighting for all these issues. And my life is easier because we have her first doing all this job, but I think we need to keep doing all her job and trying to have more people with diagnoses, with better follow-up, and maybe one day with treatments.
Yeah. Do you plan on getting the anterior segment of the eye, corneal diseases, lens diseases, dislocated lenses into the disease group that's out there? Sorry, just to expand towards the whole eye. No. Did you get it? Do you want to expand the service to include whole eye diseases, not just the retina?
Yes, for sure, like Marfan diseases, right?
One is one,
yes.
But the corneal dystrophies,
yes,
the cataracts,
yes,
that's just missing. And so there is a big field that's open.
Yes, it's a big field. Yeah, for sure. It would be lovely if we could have all these diseases treatable. And of course, I can treat as well this patient with all these years studying this, following all these professors. I feel that I can't work with these diseases, but during these years, what I studied was not in this field, right?
Yeah, sure.
But yeah.
Maybe just train somebody else who will join you, just to have that the center for Brazil, where all diseases can be taken care of. There are just few people, and it's a big country. There are few people who are interested in these diseases and who are knowledgeable. And it's a big country, so you just clearly need more people to move the subject forward. And I think you obviously need advocacy at the level of the government to get this paid for. And that's always difficult to do. So good luck with that.
Thank you. Thank you, Dr. Irene. Yeah.
Just wait a little bit for Olivia Zinn's thesis. She studied the anterior segment of the eye. So different students doing different areas. So just wait
good for you.
She's
good.
coming.
So you're getting there. Good. I think these were sort of the points I wanted to make. If you say that one more, that you know, 1 in 2,000 people, you know, basically 1 in 2,000 to 1 in 3,000 have retinal dystrophy. I think if you take the later onset disease in there, the number probably will go up. But, you know, you'll see as time goes. And I think there is a space for, indeed, public health surveys in Brazil as well as everywhere else. Do you have any regions in which there are isolates in Brazil? I think in the north, around the Amazon areas, and where new genes can be found. And I think that might be a very productive field of investigation, of collaboration with people in the US, of trying to find new genes and looking at the patients who in whom you didn't find a mutation, you know, to bring them back up and use newer technology to do the sequencing into whole genome sequencing. I think is another field that might be very productive. But I'm sure you have plenty of ideas how to move forward, and there are plenty of things to do. So my congratulations, Mariana. I think that was wonderful. It's nice to see everything being continued. So good luck to you. So it's great.
Thank you very much, Dr. Irene. Thank you for this idea about going to the north areas and everything else.
Yeah, you're welcome.
Much. It was an honor for me.
Oh, my pleasure. Good to see you.
Okay, you were good with your questioning?
Yeah.
Yeah?
I'm fine. I'm happy.
Thank you. Let's move to Ricardo Pedro Casaroli Marano. He's professor at the University of Barcelona from the Department of Surgery, and he had been in Brazil for a long time, and then he moved to Spain, and he is working with us in this combined program. So please, Ricardo, you can make your comments.
Thank you so much. No, just comment my congratulations for Mariana, Juliana, for you also. It's a very impressive work. I am so happy to collaborate with you and Mariana, and just comment that I'm very happy because today is a very important day. I think it means the consolidation of our bilateral program between Federal University of Barcelona and the University of Barcelona. This is a co-supervising program for PhD, and I am so happy for this event. I would like only thank you so much, the all Unifesp team and Joelma that works hard with us to consolidate this a day as today, and all the team and the committee, Dr. Malmini, Dr. Nilva, Dr. Maria Fernanda, and Dr. Young, Dr. Andrea Araújo Zim, and Dr. Panesi, and Dr. Mariana Valim Sales. It's a very pleasure to hear you in this committee. It's only this. I think that today may be a motivation day for the young people that is hearing for us, and to begin in the PhD program with this possibility to get the double titulation between Federal University of São Paulo and the University of Barcelona. It was and it is a big pleasure for me to could work with you, Juliana, and you, Mariana. Congratulations for your presentation. Congratulations for all data, that impressive data. It's only this. It's all.
Thank you very much, Dr. Ricardo, for allowing this supervision agreement between both universities. It's really interesting and really amazing, right? To have this opportunity to keep in contact with other universities and do all these international collaboration.
Okay, so then I will change to Maria Fernanda Balém. Maria Fernanda Balém is professor at the State University, USP, in São Paulo, and she is also professor at Kellogg Eye Center in Michigan. And she has a great experience in IRDs, and it's been really an honor to have you evaluating Mariana's work.
Good morning, all. Thank you so much, Mariana, Juliana, and all Mariana's co-mentors. I'm very honored to be a part in one of Mariana's greatest achievements. From what she said so far, I know there's so much more that Mariana is onto, and she has a very bright and long pathway in her career. I'm also very happy to be here because I've known Mariana for a couple of years, and as a professional, Mariana is a very tenacious, righteous, and competent person. And from what she explained so far in this thesis, we all have seen that she fully understands ocular genetics overall. She's we can say for sure that she's not only a one more person seeking for a PhD title, but Mariana indeed knows what she's talking about, and of course it's a result of all of these years under great mentors she has had over the past years. And as a person, Mariana is very kind and very sweet. And I'm very, very happy to be part of in this achievement you're having today, Mariana. The presentation was stellar. I have nothing to comment on the presentation. You're not on your native language, and yet you had a home run. You not only were able to present the content of your papers and a part of your thesis, you were concise, you were clear, and you have a very smooth rhythm. And it's IRD, it's ocular genetics, and nobody got bored at any point. The presentation was really stellar. Your results represent the papers you have published, and there were many of them. You've been mentored by the people who have the highest knowledge in the field. You had great co-authors, and I really don't think there's room for me here to comment on your papers. They have been extended, revised. They have been published in journal with a very high impact, and they really add something to the literature and to patient care. As to the written part of your thesis, it was also very well written. It was very concise. The objectives and the methodology were very well described. You really had the ability to discriminate the findings and to highlight what's important in your work. And furthermore, you wrote it in Spanish as well. And Spanish, it's not so easy for us Portuguese native speakers as common knowledge. So I'm not sure if you were familiar with Spanish before, but it's very nice and challenging that you wrote it in Spanish as well. And congratulations for this. I just have a few remarks regarding the thesis overall. I don't have nothing else to add to your papers. I think the objectives are a little bit loose, meaning you have like too many objectives as opposed to all what is represented in the papers you wrote. I feel that, and then I say this not just as a criticize. I think that if you have more concise objectives and therefore more concise conclusions, you will make this thesis and papers even stronger. They what already are. You looked into ultra rare diseases, which very little people have experience with, and you had so many important findings. And also, you have looked into not only the ultra rare, but also the expanded phenotype of also rare diseases. And you found so many additional characteristics that nobody has seen before. And focusing on specifically those objectives, I think it will make your thesis even stronger as not only as a candidate, but also as a researcher. You had Alagil, you have mucopolysaccharidosis, you have Bietis, that brilliantly shown. And I think if you focus a little bit on this, it's going to highlight how you understand and how much knowledge you have regarding these diseases. Let me see. And the conclusion, it's as you have so many objectives, you have to list more conclusions as well. I think I would just suggest for you to add up to the list of the objectives you list in the objective session. Just have just one sentence with the exact conclusion you had for each objective you listed. There's no need at all to change your thesis, to make amendments from my side. It's just a remark, so you understood, so you can just be a little bit more cohesive in terms of you list as objectives and what you list as conclusions. Just make it a little bit more clear on your thesis. But actually, you showed it with very good cohesion and concision in your presentation. It's just a little bit vague in the thesis itself, but I don't think it's a major component. And you don't have to write an edited version just because of that. And overall, I would like to congratulate you. You've seen that you really, it looks like you really understand IRDs, you understand ocular genetics, you have created so many great relationships, and you're onto so many things ahead of you. And I'm very happy to be part of this and this moment of your life.
Thank you, Professor Dr. Maria Fernanda, for taking the time to review my thesis and attend my PhD defense. I remember the first time I met you in a CIMASP when you were living in Michigan and you came to Brazil. I remember when you were enhancing the discussion in a session I was in. Thank you very much. I will work on improve my objectives and conclusion. I agree with you, and it was not easy write the conclusion after all this long work I have done, but I will read again and try to rewrite again for sure. Thank you.
It shouldn't take so much time because most people, we jump to the conclusion, to the introduction and some of the results, and we jump to the conclusion session, and just because of it. But it's brilliantly written. You write it very well, either in English, both in English and Portuguese and Spanish, and it's a stellar work. Congratulations.
Thank you.
Are you okay with your revision?
Sure.
Okay, thank you. The Spanish it was really a plus.
I know, and it's common knowledge that as Portuguese speakers, that Spanish it's easy for us, but it's not. There are so many false cognates out there. it's hard.
I told her, you can go, but I will not help you in this area.
Well, we will rely on Google Translator and ChatGPT on it.
Yeah.
So let's invite Professora Doutora Nilva Zimmermann Bueiro Moraes Amborghini. She's affiliate professor at the Federal University of São Paulo with me. So she's the closest people in this team. So she is the one that can argue as the last person.
Thank you, Juliana. Thank you, Mariana. Congratulations, both of you. I learned a lot of your thesis, Mariana, a lot of fantastic study. You know that I'm not a geneticist, but I am a pediatric retinologist. So I loved your thesis, and I learned a lot of this. I felt very honored to be a part of your study and your and with this team, with top of geneticists. I was honored, very honored. Mariana, I'd like to know why you became interested in rare diseases. Why? Genetic diseases are so complicated to approach and talk to the family members. And imagine was your thesis, rare diseases. Talk to me about this.
Okay, so there are some interesting things that happen in our life and lead us to different ways. And so this is interesting. I was a resident and I was in some vac days with my parents. And during this period in Tiradentes with my family there, and my parents, they make a new friend while I was in the bathroom or in other area. And they came to me with a number, telephone number. Hi, daughter. Hi, kid. This is a number of a professor in São Paulo. You can send a message to her. It was the mother-in-law of Dr. Juliana. Just you to know that. When I was a fellow at Escola, as Dr. Juliana had said before, she gave a lecture over there, and then I asked her to follow her, and everything started after this day, after her lecture over there. And at the same time she gave this lecture at Escola, I saw a patient, a child, during Saturday clinic as a fellow. I was working, and a child with a suspicion of an inherited eye disease. And I didn't feel comfortable about diagnosing and saying to the family the follow-up and what is the best approach for that child. And I was really worried because it is a child and the vision is very important for the child development. So this is the reasons why I asked Dr. Juliana, please, I want to follow you. I want to learn more about this disease. And I fall in love because when we study genetics, you understand a little bit the pathophysiology of the disease, and you can do new associations. You learn to deal with patients, and you deal with situations that we are not we don't have this kind of knowledge during our formation. I think patients that can have difficulties in their daily emotional, social, economic activities. So in this field, I was able to be in contact with these kind of patients, how to give the best as we can even when we don't have a lot to do, but I think it's because of that.
Very
I
good.
don't know if,
Yes.
yeah.
Yes, yes. I like very much your history. I don't know. It's good to be the last to talk because I don't have anything to comment. It's good to be the last. And so finally, Juliana, congratulations, because you put together a great team with working with you. Congratulations. I know you since you are a resident, so I know what your change the life of your students. So congratulations, Mariana. Congratulations, Juliana. And thank you, Mariana, to invite me, to put me together with this great team in your thesis. Thank you.
Thank you, Dr. Nilva, for accepting the invitation, for being here today. I know you are a really busy woman here in Brazil, doing a lot of surgeries, taking care of the kids in this country. And it was an honor to me, that you accept this invitation. It was an honor to me also to follow you during the iNursery examination. Thank you very much for everything you have done in this field.
Thank you, Juliana. I'm done.
Okay. Thank you for the words you spoke about the team that we raise here. You are testimony that I have been alone for many years. And then indeed, Andreasin was part of the clinic in the past, and Rosane, and Marcia. And just after Mariana Valim de Palma, that Mariana Valim Salles, oops, I mixed up. That we really started doing I think the work in a different level, bringing more of the molecular biology that we have been learned outside Brazil to the clinic, and I think the patient took a lot of profit for that. Irene, I have been involved in many advocacy tasks, and maybe it's not clear that for Mariana da Palma yet, but I think all the team will have to work a lot in advocacy. That's the next step. But this will come very naturally when you deal with rare diseases, because we need to make sure that the human rights are kept in a good way for them, because they have a lot of burden in their lives, in health, in many issues of the daily life. And since this is not solved, it became part of the doctor challenges too. Studying rare diseases allows us to see the disease in a different shape, and I think that was really important for Mariana. And also thinking the individual, and for the patient group, it's very important that they know that this even a rare disease is being taken care, because sometimes they think that, oh, nobody is going to find a treatment, nobody is going to study my disease. So it's very good that they feel that they have been taken care. It's really been a pleasure to have Mariana in the team, and I hope she is this just a start, and she had a very beautiful career. She's finishing here, but she already have a lot of international connections, so I can see very good things for her future as a doctor, starting from my mother-in-law story and medical futures. When we arrive in the end of the doctor formation, you just have to make some polish and make them shine. It's really her, and I hope she shine throughout her career. Okay, so a lot of good work. Do you want to speak something else? No?
Yes, I would like to thank you for sure for everything, for teaching us so much during these years and all your work you have done during our country to try to become more accessible, everything, genetic testing, treatments, and for being an inspiring professor for us to try to improve us as personnel, as friend, as colleague, as a doctor, as a surgeon, and everything else. Thank you very much.
Thank you very much. It's my pleasure. I would like just to give the word if Professor Po Young is in the neighborhood. He wants to say something, feel free to come in. And after that, we are going to open a second room only for the professor, just to do the final decision on her approval. And then we come back to this room again.
Can you hear me?
Yeah.
Hi.
Yes.
So, excellent presentation. It's been really nice seeing you present all your work. And I think, as Mark said, you know, you don't often see the emotional side of, you know, the experience, but you know, for the manuscripts that we wrote together, I remember all the times that you were in clinic and all the times that we went back and forth on the manuscripts and developed the figures and taught you how to use Photoshop. So I had so many good memories, and I think we don't always get that, you know, in the thesis defense. And so I just want to reiterate that it's been such a pleasure, Mariana, to have you and to be part of your training. I'll always remember this experience with fond memories. Congratulations.
Thank you very much, Dr. Yang. It was a pleasure for me.
Mariana, just go ahead.
Yes, it was a pleasure for me being able to go to the KZI Institute and follow Dr. Yang, Dr. Pinisi. Dr. Yang also has a very knowledge about autoimmune disease, and it was really good to learn from his knowledge and how they talk with patients, how they take care about the emotional side of the diseases as well, and living in another country, trying to learn another language, another culture, and everything else. It was the best academic experience in my life, going to KZ and being there. For sure, it is unforgettable. Everything 2020 was unforgettable for me because everything that I learned with both of you. For sure, thank you very much for being part here, for your time and reading everything and reviewing and teaching me how to use Photoshop as well.
It was really, I have to say thank you for all the team from KCI, because you brought a lot of opportunity for all my students, not only for Mariana. And it's really a great opportunity to merge the rare cases. When you are studying rare disease, you have to connect it to people to try to bring more patients together. So only good things to work with this KC team. And I also would like to thank Mark, because he was there too at that time. And Mariana, you just mentioned 2020, but I would like to make a point that everything that Mariana did was even during the pandemic. So it increases a lot the challenge that she went through. But I think she took a lot of profits. She did not stay waiting for the COVID goes away, she struggle and work it and make her program even with the COVID. So congratulations. So a lot of thanks, and now let's move to the second room. I think I will invite all the professors to go to the other room, and then we come back with the results in this room. The people can wait here for a little while, okay?
Mari, tá todo mundo aqui querendo nesse momento de paz.
Obrigada. Mari, Gabi, Luiz, Caio, Érica, Maju, obrigada.
Foi top,
Rebequinha.
tá aqui.
Rebeca e o neném.
Mais A Rebeca chega, lota a sala.
Obrigada.
Foi linda a aula, Mari. Foi linda.
Obrigada.
Parabéns.
Gostaria de agradecer também as mensagens aqui no chat, estou vendo aqui agora.
Eu salvei tudo, depois te mando.
Obrigada.
Qualquer coisa que precisar, chama, estamos aqui.
Obrigada, doutora Sung. Mandando aqui a mensagem. Obrigado, Ronaldo. Dr. Pinici, for your message in Portuguese. Thank you.
You're welcome. I had some help.
Yes, I can imagine.
Mariana, how do you feel?
So I don't feel nothing, right? Yeah, it's like that. But I was nervous in the beginning, so now I'm more relaxed that I could say everything that I wanted to say, and speaking in English that is not our native language is really hard. So
I'm so impressed with your English. It's awesome. You just did great, really, really great. And to do something professional in English is a whole different story. So that's great. Congratulations. It was awesome.
Thank you very much, Linda. Thank you again for the opportunity for being at Beaverton, studying English until nowadays with you.
Absolutely. I'm so glad.
It's amazing to keep in contact with the language,
right,
with native people. It's good for us to improve our English.
Well, you know what we need to do next? We need to make cookies.
Yes, we need to make cookies. Please.
It's great.
Paro was also here in this room.
Yeah, I saw her name.
Yeah.
She signed in.
Yeah, she had a doctor 8 a.m. So I think.
Oh, wow.
Yeah, she helped me a lot for this presentation.
Oh, good. Oh, I'm so glad.
Yes.
Are you in her class now?
Yes, I am. I am in her class now.
That's great. Well, great job. Congratulations.
Thank you very much, Linda, for everything.
Yeah. We'll see you soon.
Yes, see you soon.
All right.
Excelente trabalho, parabéns. Aqui é a Maria Júlia da Retina Brasil.
Obrigada, Maria Júlia. Muito obrigada aí pela parceria, por esses anos. Muito obrigada mesmo. Todo esse nosso trabalho é buscando melhorias para os pacientes, com certeza.
Uhum. E obrigada por abraçar a nossa causa, viu?
Sim, com certeza. O prazer é todo nosso.
Can we do a print screen of this group? If everybody can open your camera, please. It would be good for Mary to memorize this moment. Let's see, everybody.
Ok.
Maria Júlia.
Oi?
Smile.
Thank you. Estamos com você aqui, Mari.
Só esperando lá.
We are back. Julia is here. Hello, Julia.
Olá, Juliana. Hello, Juliana.
Olá. So we have a
Olá.
patient group spy here. Okay. Temos espião do
And it
grupo de
doesn't,
pacientes.
there we go. Okay. So we are here to announce the unanimous conclusion upon having read your summary of your work and your all of your papers, and you listen to your presentation. Sorry, and we are all very impressed with your performance, and the unanimous decision was to give a certification that says you have passed this doctoral thesis with a degree of magna cum laude. So my congratulations, and I'm sure everybody is joining into those. There you go.
Thank you, Irene, to bring the approval information to Mariana. Mariana, congratulations. You really deserve it. It's a beautiful work that you have been doing all these years. So congratulations. And I see people here putting some emojis just congratulating you. So it's really a great pleasure to guide you during those years. So today is the day to celebrate. Congratulations.
Congratulations, Mariana. Go have a drink and sleep today. You're done.
Congratulations to Danilo. Hi, Danilo.
Thank you very much.
Thank you so much. Congratulations, Mariana.
look
Thank
forward to seeing you soon somewhere, you know, US Academy, genetics meetings. So good luck to you.
Thank you for all of you to be present here in this morning and afternoon for some. It's really a great honor for the Federal University of São Paulo to have all you here. So thank you.
Thank you.
And let's close.
Thank you.
Thank you.
Thank
Thank
you.
you.
Thank you very
See you.
much.
Hope to see you soon.
Thank you.
Thank you all.
Good.
Thank you.
Welcome.
Congratulations, Mariana.
Thank
And
you.
Juliana.
Oh, there you are.
Hi, Dr. Malmany.
Hi, good to see you.
Yeah, you too.
How is your life? New life now?
Yeah, new life. I'm here in lab at the NIH. It's been great. Yeah.
Great. Nice to see you.
You too.
Let's see.
So, yeah, okay.
Bye, Irene.
Thank
Bye
you.
bye.
Thank you very
Thank you
much.
Thanks,
very much.
everybody.
Luciana,
Bye-bye,
Mariana,
everybody.
Liana, thank you.
Thank
Thank you.
you.
Thank you
Thank
for
you,
all.
Irene.
See
Thank
you
you.
soon.
Oh,
See
you're
you soon.
welcome, everybody. My pleasure to be here. My pleasure to meet new people. So this is great. So wonderful. Good luck to everybody.
Yeah, Mariana is
Thank
going
you.
to
Thank you so
the
much.
academy. Maybe she will meet you
Yes,
there next week.
this weekend
Okay.
I believe
I will
Civintal
be
is coming
there.
too. I just saw.
Yeah.
Victor Civintal Tadeu. Professor
Yeah.
Tadeu, nice to see you. Great honor to have you here too.
Yes.
Okay. Bye-bye.
Bye, Dr. Juliana. Thank you. See you.
See you.